We'll begin with some unknown cases. Not going to give you any history here. Case number 1. Case number 2. You get a prone and a supine, more delayed image. What do you think is going on here? Case number 3. This is just for fun if you want to jot down your ideas, and these cases are all embedded in the lecture, so in addition to that, I'll come back and show you the answers at the end as well. Case number 4, this is a T2 axial image of the prostate. And case number 5. Okay, so the objective here is to discuss these topics, so not too many, but there's a few little miscellaneous things related to the bladder, prostate, and urethra that are worth going through and discussing in a little bit of detail. So let's begin with bladder cancer, and of course I'm excluding trauma and pediatric topics which are dealt with separately. So bladder cancer, it's not that common. It only accounts for about 2% of cancer deaths, but it's not negligible either. That's still a sizable number of people in North America. The major risk factors for transitional cell carcinoma, and remember most of these cancers are transitional cell carcinomas, so those terms are almost but not quite synonymous. Big risk factor is smoking, certainly aniline dyes, and so job exposure can be a factor. But in reality, even in those who have been exposed to aniline dyes who get bladder cancer, most of them are smokers as well, so it's pretty unusual to get a TCC in the absence of being a smoker. And of course, age, the older you are, the more likely you are to get most any cancer. Squamous cell carcinomas, these tend to arise in the setting of some background chronic abnormality, be it stones or chronic inflammation. And then finally, about 2% of all bladder cancers are adenocarcinomas, so it's pretty uncommon. These can arise also in chronic inflammation, but actually seen a few of these associated with congenital abnormalities, in particular urachal defects. So if you see a big mass in the midline or even a smaller mass in the midline anteriorly where the urachal remnants occur, think about that being a potential urachal adenocarcinoma. I've seen a few of these over the years, and the location is the clue to the histology, the fact that it's sitting in the midline anteriorly on the dome. Here's another one. And here's one more. These were all adenocarcinomas, presumably arising within urachal remnant. Bladder cancer is a variable morphology. These are all polypoid masses. In passing, I would note that at CT, you may see, occasionally you'll see surface calcification, and that's a pretty good indication that you're looking at a TCC. For whatever reason, that histology likes to develop this surface incrustation or calcification. Here's a little bit more of a subtle example of surface calcification. If anything, maybe arguably obscured on the delayed image because of the presence of contrast in the bladder, probably better appreciated on the non-contrast image. In any event, in addition to being polypoid, you can also get infiltrative morphology. It turns out that the polypoid masses tend to be the lower grade tumors, whereas the more infiltrative masses tend to be the higher grade tumors. So here are some examples. These are all different patients. These polypoid masses, and it doesn't really matter what the modality is that you use to see them, they all have similar morphology. These polypoid masses are typical of low-grade transitional cell carcinoma, whereas the more infiltrative abnormality, and again, doesn't matter which modality you use, and these happen to be 3 different patients, but these more infiltrative abnormalities are typical of the higher grade tumors, which of course is somewhat unfortunate because it means the cancers you really want to find, that is the nasty, aggressive, high-grade tumors, are actually a little bit more difficult to see. These infiltrative abnormalities, of course, can be a little bit harder to appreciate. How does imaging do in the detection of bladder cancer? Well, again, it doesn't much matter which modality you use. Our detection rate, in the ballpark of 70-80%, so it's good but far from perfect. And the reality is that all imaging modalities can miss flat tumors, and we can all presumably miss small tumors no matter what modality we use. And this is why cystoscopy is the gold standard for the detection of bladder cancer. And that matters because if you're asked, what tests do you need to do in a patient with hematuria, remember you're looking for urologic malignancy. That's why you want to image those patients, and probably Years ago, you would have said IVP and cystoscopy. Nowadays, probably the answer is CT and cystoscopy. But it is important because I think sometimes clinicians think if they order a CTU that they are done in terms of assessing the urinary tract, and that's not true. And certainly when I report back to someone who is not a urologist, urologists know this, but other specialties may not, at the end of my CTU report, if it's been done for hematuria, I routinely put a little disclaimer that this does not obviate the need for cystoscopy as clinically appropriate, because I don't know if that physician knows that information, and they may not. Staging of bladder cancer, again, I wouldn't attempt to commit this table to memory, just be aware of the kind of big picture issues. It may just be superficial, and that can be treated endoscopically. They can just chip away at that. They may give intravesical chemo or BCG. Superficial cancers, which is most of the cancers, good prognosis, they can be treated locally. Then you get to the next level up, that is invasive cancer, either into the muscle layer, into the perivesical fat, or into the regional nodes. These are more aggressive tumors. They need more advanced treatment, either radical cystectomy or radiation. And then, of course, the worst case scenario, it is more distantly metastatic, which is only 5% of tumors, bad prognosis, and they need, of course, systemic treatment. So just remember the sort of general groupings here: superficial, invasive, and metastatic. Now, it turns out, and there's a lot of literature published on the ability of imaging to detect the different types of invasive cancers, that is, whether it's into the muscle layer, into the perivesical fat, or to the pelvic lymph nodes. And I will spare you the pain, since I've done it, of looking at this literature. The bottom line is that imaging, no matter how it's done or what modality you use, is somewhat limited for all of these assessments. And if you were to say 70% accuracy across the board, that would probably be a pretty good number. You'll get people who claim that, or you'll find single papers that show a little bit higher accuracy for individual modalities, but it's really not borne out across the wider literature. So independent of whether, now that isn't to say, of course, you shouldn't look for the findings, even though we may not be that accurate, you're still obliged to look. So you do need to look for local nodes, as for example here, this big circular juicy node looking very suspicious in this patient with an infiltrative bladder cancer, which we know, of course, indicates a higher grade tumor and therefore a higher propensity for nodal spread. Here's another big nasty cancer with this little sort of triangle sticking out, very concerning for perivesical tumor extension. And in general, if I just see a little bit of fuzziness of the perivesical fat, I don't call that extramural extension. But if I see a little nodule or finger of tumor actually growing out into the perivesical fat, then yes, I do call that extramural extension. Another important concept to remember in bladder cancer and TCC is that it is a field cancerization. That is, we believe if you have a TCC anywhere in the uroepithelium, the rest of your uroepithelium is predisposed to develop another TCC. And here's a patient who had been treated for several years, I believe, for this bladder cancer with endoscopic fulgurations and so on, and finally came to imaging of the upper tracts and had this really advanced TCC. There was an obstructive TCC lower down the ureter, and here you see TCC growing within these dilated calyces. So, the failure to check the upper tracts clearly had allowed this to become quite advanced. Recurrent bladder cancer, for whatever reason, bladder cancer loves to come back against the pelvic sidewall, so you want to look very closely at the pelvic sidewall in patients who've had a radical cystectomy. This may not be so relevant for Louisville, but it is certainly relevant for real life, and here's the corresponding PET showing that this is indeed a focus of metastatic recurrence. Another thing about TCC, you heard about HCC this morning being one of those tumors that likes to implant along biopsy tracts and so on. This is also true of TCC. It is one of these tumors that will grow in suprapubic catheter sites, in biopsy sites. It will implant along the scars and stuff. And here are two examples of abdominal wall implantation related to suprapubic catheter placement. These are two different patients. Big nasty tumor mass here implanted in the anterior abdominal wall. Here's a sub-Q-met in another patient who'd had a suprapubic catheter related to TCC, and clearly it's metastatic, hot on PET. Obviously, if you see a mass in the bladder, you have to worry about it being a bladder cancer. There are other things that you might see or be shown in the bladder, and here's a list of things you might want to know about. as sort of a backup differential beginning with hematoma. And this was proven quite nicely in this particular case. This sort of worm-like filling defect, you might think about hematoma just on the morphology, but you flip the patient over, it falls to the other side. Clearly, that's got to be hematoma and not a mass. However, that doesn't mean there couldn't be a mass there as well, be it one that's visible to you at imaging or not. Here's one that happened to be visible at imaging, and that's an important point. Just because you figure out it's a hematoma doesn't mean that the patient doesn't have a cancer. Here's a patient, and again, I don't think you'll be shown anything this complex in Louisville, but this component was an enhancing TCC, and then next to it was some non-enhancing hematoma. But it does make the point that simply identifying hematoma doesn't mean you've cleared the uroepithelium of having an associated malignancy. If you see a really smooth filling defect in the bladder, think about leiomyoma. This is the same patient, 3 different modalities, a somewhat dumbbell-shaped, very smooth tumor in the bladder wall, and a little bit bright on T2, but this was a proven leiomyoma. And remember, we, of course, typically see leiomyomas in the uterus, but they can actually occur anywhere you have smooth muscle, including the bladder wall. So, if you see a bladder mass and you say TCC and they ask you what else could it be, think about leiomyoma, particularly if it's smooth. Schistosomiasis, this is kind of an ant mini. I've never seen this in real life, but here it is if you get diffusely calcified bladder wall, perhaps tracking up along the urethra, as you see here in the magnified view. This is the appearance of chronic schistosomiasis, hematobium. Hematobium is the one that calls hematuria, so the 2 hemes go together, and you can remember it that way. Hematuria from hematobium, schistosomiasis hematobium. You're meant to look at this calcification, and if there's an interruption, you would suggest that there might be a superimposed squamous cell carcinoma, because this is one of those chronic inflammatory conditions that can lead on to squamous cell. Again, I've never seen that outside of textbooks, but if you want to look well informed, I guess you could make that comment. Different thing you might get in the bladder, occasionally you see a pheochromocytoma. I wouldn't offer it as your first differential, but if it's a smooth, very enhancing mass and they're pressing you for more options, think about pheo. And at that point, you might want to ask, does the patient have syncope when they micturate? And you look really clever making the diagnosis of pheochromocytoma. They may be benign or malignant. These are 2 different patients. This was a small benign pheo in the bladder. This bigger, nastier mass turned out to be a malignant pheo. Okay, let's move to a different topic now, that of neurogenic bladder. If you look at the urology or neurology textbooks that talk about bladder innovation, you'll see very complex classifications of neurogenic bladder, and essentially they need a full urodynamic and EMG workup to really figure that all out. The good news is you don't need to know any of that stuff, because the radiological classification of neurogenic bladder is really simple. It's either spastic or flaccid. The spastic neurogenic bladder is the typical pine cone. It's small, it's trabeculated, it's conical, got these little diverticula, trabeculated appearance. The pine cone or Christmas tree bladder, that's typical spastic neurogenic bladder. The flaccid neurogenic bladder, or the atonic neurogenic bladder, this is a little bit more difficult, but basically it's a really voluminous bladder, very capacious. And of course, it's a little bit tricky sometimes to tell, is this just a top normal bladder that you could, fly from here to New York on, or is it just actually a flaccid neurogenic bladder? One clue is to look at the rectum as well. If they truly have a flaccid neurogenic bladder from, some kind of neural problem, they may very well likely have difficulty defecating as well as micturating. So if you see a distended rectum, that would favor it being a flaccid neurogenic bladder. Here's some examples. Spastic neurogenic bladder. Here's a typical pine cone bladder. If you see something that looks funny in the bladder, look at the spine. And if you look closely here, and the reason the scout view is that this patient has sacral agenesis or caudal regression syndrome. You can see the sacrum here is missing. Another patient, spastic neurogenic bladder with reflux, in this case, into the dilated right ureter and pelvic calyceal system. But remember, you're not done when you've just looked at the bladder. Look around for clues as to why that patient has a spastic neurogenic bladder. And in this case, you can see there's a dislocated hip, and in addition, there's a big defect in the spine. This is spina bifida with a spastic neurogenic bladder. Here was a young woman who presented with difficulty voiding, big bladder. This is the flaccid type of neurogenic bladder. And again, why is this image up here on the right-hand side? look at the spine. This is the spinal cord here. This is all thickened, enhancing meninges. This patient turned out to have TB meningitis. Guess it could have been leptomeningeal carcinoma as well if she had breast cancer or lymphoma or something, but this particular patient had TB meningitis. So the big message for all of these cases is remember the spine if you see a funny-looking bladder. This is just a sort of observation I've made. Not uncommon in these particularly older patients, really old patients, to see kind of a big, baggy, what I presume to be a atonic or flaccid urinogenic bladder. And if you look at the spine, they'll have these really degenerative, crappy-looking spines, and I suspect this is just a sort of spinal myelopathy causing an atonic, flaccid urinogenic bladder. This is my own observation. There's nothing in the literature. Probably not going to come up in Louisville, but something you might notice in your practice. Okay, well, let's talk about the prostate now. And there's a few things you need to know about here, beginning with the zonal anatomy. I think people get really confused about the zonal anatomy of the prostate, and this is, again, independent of whether you're looking at it with ultrasound, CT, or MRI. But remember, the zonal anatomy of the prostate is, the analogy is it's like a scoop of ice cream sitting in a cone. And the scoop of ice cream, which is the central gland, sits in the cone, which is the peripheral zone. In younger men, the peripheral zone makes up about 75% of the prostate by volume. This is the part of the prostate that develops cancers, most of the cancers at least. The central gland in younger men is made up mainly of central zone, and then there's a little bit of tissue around the virumontanum, which is the transition zone. The reason that the zonal anatomy, I think, gets confused is that this changes with age because the transition zone is the bit of the prostate that develops benign prostatic hyperplasia. So when you start getting to my age or beyond, this is what it's going to look like. The transition zone is now hyperplastic, starts to compress the central zone as the pseudocapsule, and ultimately may also compress the peripheral zone. It's easiest to remember the two-compartment model. You have the central gland sitting in the peripheral zone, but remembering that in young men, the central gland is mainly central zone. In older men, the central gland is mainly transition zone, so that in older men, and certainly the population that come to imaging for prostate cancer, the terms transition zone and central gland are essentially synonymous. So here are 3 different patients in order of age, and in fact in young men, not alone is the central gland mainly central zone, but you can't even see the zonal distinctions. They're not imaging apparent. And however, as that transition zone starts to become hyperplastic, you begin to see the central zone sort of forming the blacker pseudocapsule around it. This is peripheral zone here. And then finally, you may end up like this, where virtually everything you see is hyperplastic transition zone, the typical kind of nodular, bubbly look of BPH, with just a little thin rim of compressed peripheral zone out here at the outer margins of the prostate. The one part of this analogy that doesn't quite work, the scoop of ice cream in the cone, is that the cone, that is the peripheral zone, is deficient anteriorly where you have the fibromuscular stroma, which of course is somewhat convenient because it means the peripheral zone, which is the part of the prostate again that develops cancer, is mainly posterior and lateral, where it's readily accessible to the examining finger. So again, one more time, central gland, peripheral zone. Two-compartment model, that's the easy way to remember it. If you can remember the additional parts of the central gland and the change with age, fine, but otherwise just remember central gland sits in the peripheral zone. So that's important because we do need to know that anatomy if we're going to look at the prostate, and of course we would particularly want to look at the prostate for cancer. This is the commonest non-cutaneous cancer in men. While you often hear the glib statement that men die with prostate cancer, not of it, in fact, it is the second commonest fatal cancer, second only to lung in men. So it's really quite analogous to breast cancer in women. And of course, staging is critical when you're trying to plan prognosis and plan treatment. Again, staging, this is a little bit like the bladder cancer. In the big picture, there's only really 3 stages of prostate cancer. It may be confined within the prostate, that is organ-confined disease. It may be locally advanced, meaning it started to grow outside the capsule, or it started to grow up into the seminal vesicle, or finally, it may be metastatic, typically to bones, as here. This is an acetabular metastasis, or to nodal disease, or to nodes, which we see as well, pelvic or retroperitoneal nodes. Those would be the typical sites of metastatic spread. becomes a little bit more tricky, if you will, because they actually break down the organ confined into impalpable versus that which is palpable. It actually turns out so you end up actually with 4 stages. Turns out not clear that distinction is particularly useful, but the urologists make it. The locally advanced disease is broken down into which there's just extracapsular extension versus that in which there is seminal vesicle invasion. And then the metastatic disease is broken down into just pelvic nodes versus more distant mets. I wouldn't try and remember the more detailed divisions. If you can keep in mind the big picture, it's either organ confined, locally advanced, or metastatic. I think that's good enough. Again, I wouldn't attempt to commit this table to memory, but just be aware, of course, as your stage goes up, your prognosis goes down, and your mortality goes up. And in particular, you'll notice if you have T3 disease, that is extracapsular extension or seminal vesicle invasion, these are the locally advanced tumors, you have a fairly sizable mortality at 5 years and a fairly high likelihood of recurrence if you go to radical prostatectomy. And this is why most urologists, though not all, believe that if you knew the patient had locally advanced disease, you would not operate, you would offer that patient radiation treatment. The problem, of course, is our ability to identify those patients, those who have extracapsular extension or seminal vesicle invasion, is of limited accuracy, and this is one of the reasons we like to image prostate cancer to try and improve that. So again, if in a simple world, if you knew the patient had organ-confined disease, they're probably candidates for any of the major approaches, radical prostatectomy, radiation, or watchful waiting. If you knew the patient had locally advanced disease, you'd probably go to radiation treatment. And of course, if they have more advanced disease, that is systemic disease, they need systemic treatment, which basically means hormones followed by chemo when they become hormone resistant. The problem, as I say, is that our ability to assign patients to stage is of limited accuracy, particularly the differentiation between those with organ-confined and locally advanced disease. So one of the reasons that we image prostate cancer is to try and improve on that distinction. So what does prostate cancer look like? And it is possible for you to be shown a MRI of the prostate on the board, so it's worth knowing about. Here's what it looks like. You see it as an area of low T2 signal in the peripheral zone of the prostate. So unlike most other cancers, prostate is of low T2 signal. That's probably because it's fibrotic. There's a lot of desmoplastic reaction in these tumors, and fibrosis is black. And of course, that's why they're hard on palpation. And it may also be a relative thing. The prostate peripheral zone, it's a glandular tissue, so all these ducts and acini are filled with fluid, so they're actually pretty high on T2, so that's probably the other reason that prostate is low T2 signal, unlike most other cancers. Well, localizing prostate cancer is well and good. What you really want to do is stage it. What are the findings that indicate T3 disease? Well, you'll want to look for focal irregular bulge, invasion of the neurovascular bundles, and by the way, the neurovascular bundles is this little cluster of black dots out here. They run down in that lateral angle between the rectum and the prostate. They give branches to the prostate, and then they pass into the root of the penis through the GU diaphragm, and of course they're essential for erectile function and so on. As they pass down and they give branches, they make little holes in the prostate capsule, so this lateral angle between the rectum and the prostate is a site of predilection for extracapsular extension, and here you can see a vessel that's been surrounded by tumor growing out right in that angle between the rectum and prostate laterally. Medially, the angle between the rectum and prostate is usually a nice acute angle. If you see tumor filling in that angle, which is not a common sign, but if you see that, it's got a very high positive predictive value for locally advanced disease. That's known as rectoprostatic angle obliteration. And of course, finally, you may see tumor growing up along the seminal vesicles. That also indicates T3 disease. So, as I say, just to go back here for a moment, if you are shown a prostate in Louisville, it's going to be something that's really easy. So, don't lose control of your sphincters. It'll be okay. It's going to be probably a big, obvious tumor. There's likely to be big extracapsular extension or seminal vesicle invasion, maybe nodal disease, but probably it's going to be big-time ECE or SVI. So, it'll be okay. Moving now to the urethra, strictures, and of course really this is something that occurs virtually exclusively in the male urethra because of its length. The anatomy you should know about, there's a posterior part and an anterior part. Each of those is divided into two pieces, sub-pieces if you will, the prostatic and the bulbar part is the subcomponents of the prostatic and the membranous part in the sphincter are the two components of the posterior urethra. Then the bulbar part and the penile part in the shaft are the two components of the anterior urethra, and you should probably know that terminology and be willing to use it. Urethral strictures, these are, as you'll see in your books, a long list of causes. It is interesting to me that urologists don't seem to give a hoot as to what causes the stricture. They just want to go fix it. I'm not sure. A lot of times they're just idiopathic. Sometimes they're post-traumatic. Maybe it's old STD. I don't know. But the urologists don't seem to work up these strictures for cause, except for the very occasional one that's malignant. That's highly uncommon. They're nearly all benign fibrotic strictures. They do want to know how long it is and where it is. And to really do that properly, you need to do both a retrograde study and a voiding study. So let me show you why. If I just showed you this rug, you might call it normal. You might say there's a stricture in the prostatic urethra, but remember, that's not a relaxed urethra. It's only when you get during voiding that you can properly assess the posterior urethra, and in fact, that is dilated down to the level of this little focal stricture here that's sort of hidden in here and a little bit difficult to see. So you really need to do both studies to adequately evaluate for the presence and length of a urethral stricture. The length, don't measure just a narrow little bit here. You want to measure between the shoulders, as it were, and that is important to the urologist because it turns out if it's over about 1.5 cm or so, they won't be able to do a primary reanastomosis where they just snip out the bad bit and pull the two ends together. If it's longer than 1.5 centimeters, they need to get more creative. Sometimes they take a buccal flap from inside the cheek and sort of make a little bit of neo-urethra, if you will, and put it into that gap. So when you're measuring the length, you want to make sure you include the shoulders, and you can see why on this intraoperative ultrasound, because of course the stricture or the fibrotic component extends all the way out to those shoulders parts pathologically. Finally, urethral diverticula. This is actually apparently quite common in adult women, estimated 1 to 6% of adult women. They're thought to be probably an acquired condition. No one knows for sure, but they think it's related to infection or obstruction of the periurethral glands, resulting in a cystic dilatation. They cause various urethral symptoms, frequency, pain on voiding, dysuria. They can get infected, so they can get pus. They can even develop malignancy as well. They can get stones, so they can cause quite a lot of morbidity, and they can be somewhat occult both clinically and radiologically, so it's worth knowing about these. As I said, you may not see them on a standard VCUG, so there are things you can do to try and really tease it out. One is a so-called double balloon urethrogram, where you have a special urethral catheter with a balloon in the bladder, but also one that's inflated against the external meatus, and then there's a hole in between those two balloons, so essentially when you inject contrast, it's driven out into the urethra, which is sealed, as it were, top and bottom, and you can fill that diverticulum under pressure, so that double balloon technique is one trick, as it were, to demonstrate this condition. The other thing is just do an MRI. They're actually quite evident on MRI, and I'll show you some examples. Here's that double balloon technique. Here's a big urethral diverticulum filling on this, as I say, double balloon VCUG. Here's one demonstrated on CT, and they're typical when you see them, but they sometimes go unrecognized. This is not partial voluming with the bladder apex. Go back to the bladder. These are arranged from top to bottom. Here's bladder neck. You're out of bladder here, and then there's this new cystic structure. You see it conforms to the shape of the urethra. It looks like it's kind of partially wrapped around the urethra. That's very typical of a urethral diverticulum. Here's one at MRI, again, that sort of partially wrapped appearance around the urethra sitting here, very typical. Another one, again, you see it, a different patient, CT case. Here it is, wrapped around the urethra. This one actually has stones in it. Another example. Yet another example, urethral diverticulum sort of wrapped around the urethra. You can image these better with an endovaginal coil. I'm not sure that this extra detail really helps you, but it's certainly something that has been done. I know they do this routinely in Mallinckrodt, for example. Not totally sure what this extra information does for you, but it's certainly an option if you want to better delineate the urethral diverticulum. To wrap up, bladder mass, most of those are going to be TCCs, but remember the differential, including other cancers such as squamous cell and adenocarcinoma, and then things that are not malignant at all, like hematoma, pheochromocytoma, leiomyoma, as differentials. Remember, radiological staging is of limited accuracy, but you still need to look for perivesical invasion, lymph node metastasis. Those are important observations. For prostate cancer, nodozonal anatomy, and remember, extracapsular extension and seminal vesical invasion are the key findings, and they're probably the imaging findings that you're likely to be tested on. The urethra, remember the anatomy, and remember that you need both a VCUG and a RUG for full assessment of its stricture, and remember the urethral diverticulum as an ant mini. Unknown cases, this is bladder TCC, typical surface calcification. This is blood clot, mobile on prone and supine imaging. This one is a neurogenic bladder due to sacral agenesis. Number 4, big prostate cancer with extracapsular extension. And finally, urethral diverticulum.